Good evening and welcome everyone. Thank you for joining our webinar around frailty management in primary care and the CARES model. My name is Katie Perch and I'm a project coordinator with the Quality Impact team at the Doctors of BC, and I support the Coordinating Complex Care for Older Adults initiative with the Shared Care Committee. And I'll give you a little bit more information on that in just a minute. But before then, I'd like to recognize that I'm speaking to you all this evening from the traditional, unceded, and ancestral territories of the Coast Salish people, in particular the Tsleil-Waututh, Musqueam, and Stolo First Nations. Since we're gathered virtually from all over the province, please take a moment to honor and recognize the land that you're on that's giving us this opportunity to learn, share, and work together. And if you're not sure which traditional territory you're on, please visit nativeland.ca to find out. So as you may know, this webinar is brought to you today by the Coordinating Complex Care for Older Adults initiative. We call it CCC for short. And this falls under the Shared Care Committee with Doctors of BC. So the Shared Care Committee is one of the joint collaborative committees, and it's a partnership between the Ministry of Health and the Doctors of BC. Shared Care focuses on supporting family and specialist physicians to collaborate on healthcare improvement initiatives. And the CCC initiative, which falls under Shared Care, was created in 2017 with the goal of supporting communities to improve the coordination of care for older adults with complex medical conditions in community settings. And we have a particular emphasis on medication management practice implementation, referral protocols and communication, and coordinated care plans and responsibilities. We're really excited to connect with Dr. Park and Dr. Rodas around the CARES model and the comprehensive geriatric assessment tool. The comprehensive geriatric assessment tool can be used as in complex care planning, and Dr. Park will be able to provide more information later on. So this is our first webinar in a while, and so if there are any other topics that you'd like to see from us in the future, please feel free to provide that feedback in the post-survey event that will be distributed afterwards. So our presenters this evening are Dr. Belinda Rodas, who's a geriatrician practicing in the Fraser North region, and Dr. Grace Park, who's a family physician and the Regional Medical Director for Home and Community Care in the Fraser Health Authority. And their full bios can be found on the agenda, which has been linked in the chat box below. Following their presentations, there will be time for questions. Please feel free to use the Q&A box at the bottom of your screen for any questions that you may have throughout the presentation. And if we're unable to get to your questions this evening or to all of them this evening, we'll send out the responses in the next few days. So without anything further, I will pass things over to Dr. Rodas.
I'm Belinda Rodas. I'm one of the geriatricians here. Thanks for inviting me. So I was going to talk about frailty from the geriatrics perspective, and I was going to leave it to Dr. Park to talk more about the specifics of the CARES initiative. But my outline here is I'm going to talk first about what frailty is. So I'm going to talk about components of a frailty assessment, what outcomes are associated with frailty, and then what we need to do and what we can do to, one, prevent frailty, and then two, manage frailty and manage care planning around frailty. So we'll get started by talking about definitions of frailty. Basically, frailty is a syndrome of vulnerability. It outlines someone who appears to be managing well, but they have less reserve. So someone who is more frail, a stressor, whatever that stressor is, whether that's an illness, whether that's a surgery, anything that goes on, that stressor in someone who is doing very well, it will cause a little blip in how they're doing, and then they will return back to their baseline of function. When we're thinking about people who are more frail, so people who are mildly frail, you can have a decline in their function. So a common pattern that I see is that people will be frail, they will have an illness, and they won't quite get back to their baseline of where they were before. And this is what we're trying to prevent. We're trying to keep people in that managing well stage, or at least keep them in milder levels of frailty, so that an acute illness will perhaps take them down a notch from functionally where they were, but they can at least continue to be fairly independent. So when we talk about frailty, there's multiple different domains of frailty. There's lots of things that encompass frailty, and there's some changes going on in the body as well. In the endocrine system, there's decreased testosterone, increased cortisol, there's higher inflammatory markers, and there's also a change to the way the body metabolizes glucose, the changes to the autonomic nervous system, and that all affects the body in different ways. There's multiple different ways that we assess for frailty. So the first one is probably the frailty phenotype, and that's just looking at how patients present physically. There's the clinical frailty scale, and then the frailty index, which is more accumulation of deficits. And I'll talk more about these in detail, but the frailty index is what we're going to be looking at. So when we're talking about the frailty phenotype, that is 5 key characteristics. So that's someone who walks slowly, who's been losing weight, who's more weak, who feels exhausted even doing small amounts of activity, and who is not very active at all. The more of those features you have, the more frail you are. So 3 or more of those puts you in the frail category. 1 or 2 is pre-frail or vulnerable, and 0 is someone who is fairly robust. We'll look further how the frailty index encompasses lots of other components like cognition, psychosocial, things like that. And the frailty phenotype here, it does not encompass any of those. So looking more at the clinical frailty scale, this is looking at how someone is functioning. It's a brief snapshot that I'm sure you've all seen of looking at how well someone is doing. So someone in the clinical frailty score of 1 to 3 is generally fairly well. Depending on how fit they are, they may be active, they may exercise regularly, and as they become more frail, a clinical frailty score of 4 is someone who's approaching frailty. They're vulnerable. They are still functional, but they might be doing things slower. It takes them longer to do the same things that they used to, or they might find that, a fairly simple task like going grocery shopping, that might be pretty tiring for them, and they can only do that over several hours. It can take them time to recover from it. When they're starting to need more help, you end up with increasing frailty. So the more support you need, the higher the frailty index, the frailty scale is getting. Now, looking into the frailty index, this is based on a whole number of features. So it looks at things, not only physical components, but it also looks at cognitive components, emotional components, social components. It takes a number of factors of things that could go wrong in any of these categories, and you look at how many your individual patient has. So if you've picked 30 things that could go wrong, physical, social, emotional, cognitive, and you count how many your patient is. So if they, for example, have 15 of those 30 things, their frailty index would be 15 over 30 or 0.5. So this is the most sensitive aspect of frailty, and it is often the most time consuming to measure, but that's part of also where the electronic frailty index comes in, and it's the most sensitive to change. So it is the easiest to see if someone is improving or getting worse based on this. Now, when we look at a comprehensive geriatric assessment, we're looking at a number of different domains. I'll let Dr. Park go more into detail for this, but it looks at numerous physical domains, it looks at cognitive domains, it looks at their number of health conditions, their number of medications, but it also is looking at their function, it's looking at their caregiver support, whether they have enough financial supports. And with this, you can also use it to flag areas of concern. So you can flag an area where, for example, exercise, where someone could improve, something to think about as care planning. So I use this not only for identifying frailty, but I use it to care plan and think, where can I work to improve my patients? Now, looking a bit more into detail in the components of a frailty assessment, there's, like we said with the frailty index, there's lots of domains involved in frailty. There is the medical, which is probably the one that we're most concerned with generally, the one that we're most comfortable with, listing off their health conditions, listing off their medications. When we look at the physical, that's looking at how they're doing mobility-wise. How do they walk in spite of all their conditions? How does that affect their gait speed? How does that affect their ability to transfer and their mobility? And as well, looking at the cognition. Function is also a key part of a comprehensive geriatric assessment. So how they're managing with all of their IADLs, their ADLs, and as well as looking at their sensory changes, whether their hearing's okay, any changes to their vision, things like that. I also want to know about what sort of supports they have or caregivers. Even if they are someone who is quite well, I want to know what supports could be put into place informally from their caregivers if they were to have an acute illness or to become frail or sick. And then the other important parts are going to be the psychological. So how their emotional state is, how much control they feel they have over their life, and what their attitude is in general towards their health. When I'm talking more about physical assessments, what I'm looking at is I'm looking at these four major components. I'm looking at their strength. So that typically I will do through a physical exam, routine strength testing. I can also look at their 5 times sit to stand. So I have them, I take out a stopwatch or whatever time measuring device, and I ask them to stand up and sit down, ideally without using their arms, 5 times, and I look at how quickly they can do that. You can also measure their gait speed, which is a bit more time consuming. If you don't have a large hallway you can use and you don't have areas that you can use, you can also look at the time up and go, have them stand up, walk 3 meters, turn around, sit down, how much time is available in that. For balance, if you want to do it more formally, physiotherapists will often use the Berg, but more as well asking about their falls, seeing how they're walking, seeing how they stand, and then looking at transfer. So for me, that's often seeing how they're standing up. When I'm first seeing them in my office, after I call them, how easily they get up, whether they need to push off with their arms or whether they can just get up easily and, walk over to my office and sit down. When I'm looking at the cognition, there's multiple different ways to do this that are fairly easy to do in the office. The fastest one is going to be the mini cog. So all that entails is 3 words, give them 3 words to remember, and then ask them to draw a clock, and then ask them what those 3 words are. So that looks at their delayed recall, it looks at their visual spatial function, and it also looks a bit at their executive function. So whether they're able to appropriately put the hands in the correct place and properly space out the numbers on the clock. That's quick, it's reasonably sensitive. When we look at other tests, there's the MOCA. So the MOCA, as I'm sure you know, is more time consuming. It's more of a difficult test. It's more sensitive, but it's less specific. It's also fairly education-based and language-based. So it can be unfair for people that we see who maybe English wasn't their first language, or maybe they only got to a grade 5 education before they had to start working. So in those cases, the MOCA can be falsely low. The MMSE is probably one of the more common tests that we use. It's fast, it's simple, but it's not as sensitive because it is an easier test. One of the other tests that I like using these days is the RUDAS. So the RUDAS was designed in Australia in populations with limited education who didn't necessarily have the same sort of Western cultural upbringing. It's similar to MMSE in the sense of difficulty in a way, because the scores correlate pretty well. Like a 24 on the MMSE is fairly equivalent to a 24 on the RUDAS. And it is less education-based, more practical. So rather than here's 3 words to remember, it is, this is our grocery list. Imagine that we're going grocery shopping and you need to remember to pick up these items. I'm going to ask you again in about 5 minutes. It does not ask the date and the locations, because I find my patients are retired and they tell me they don't keep track of what date it is. Now, after this assessment, what I want to talk about is how frailty affects people. We know that frailty is fairly prevalent, and we know that older adults tend to cost more healthcare dollars, likely because of increasing medical conditions and increasing frailty. It also leads to a lot of informal caregiving. So when I talk about frailty, to me, frailty is not normal. It's not something that will automatically happen with age. It's associated with worse outcomes for a number of interventions. Basically anything that frailty has been studied in, it has worse outcomes the more frail that you are. It is to a certain degree reversible, and it's a warning sign to me that someone who is frail, I want to consider further care planning. I want to talk about how to prevent things, how to optimize things for them. There are lots of ways that frailty can present. This is from the BC guidelines for 2017 for frailty. And this is just some things that could be red flags to make you think about frailty and want to assess frailty. Things like weight loss, incontinence, decreased function, delirium. These are all things that aren't necessarily because of one condition. These tend to be multiple risk factors that add up that lead to these changes. So often that's a sign that we should be looking for frailty. The reason why I think frailty is important is that it helps us reduce progressive frailty, it helps keep people independent, and it helps me prognosticate. The caveat I have is that people who are acutely unwell can look very frail. So anyone who is really sick who presents to the hospital, they often appear like they're severely frail. But what you want to get a sense of is what their baseline was 2 weeks prior. So sometimes I have people who are, it's documented that they're very frail, but when you talk to the family and they show you pictures from 2 weeks ago, they were really doing quite well. They're just really acutely unwell. So when I'm talking about frailty, I'm talking more about their progressive frailty, how they've been managing long-term, not if they're suddenly sick. We know that frailty is associated with worse outcomes, so I wanted to talk about some of the things that frailty predicts. Frailty in general is predictive of mortality, even in the general community dwelling population. So the frailty phenotype also predicts mortality. You can see the clinical frailty scale on the left. The more frail you are, the lower your probability of survival. And the frailty index is the most sensitive to change. So the higher you are on the frailty index, the higher your 2-year mortality. When I'm talking about frailty to patients, I stress that this is a medical diagnosis. I tell them that frailty it's a medical condition because frailty is also used colloquially. I've seen newspaper articles that talk about gold medal winning 14-year-old figure skaters who are described as frail because they're petite, thin people, which is not the same as frailty. So I outlined that frailty is a medical condition where it's an accumulation of illnesses and less reserve, more vulnerability. I'm going to switch gears a bit. I'm going to talk about the outcomes of frailty in CPR and in critical care because I find that these outcomes help me when I'm talking about further advanced care planning with my patients and people who are quite frail. So we know that age on its own is associated with worse outcomes after CPR. And this is a study out of Vienna that looks at how patients recovered after CPR. In Vienna, at the time of this study at least, CPR is basically automatically performed unless a physician calls death or there were clear postmortem signs when someone gets there. So what they found was that the older you are, the less likely you were to have good neurologic outcomes. So CPC is basically how well they were cognitively functioning afterwards. And with each increase in age, you have a decrease in number of people who are doing well. But that doesn't mean that no one who is older does well. There are always people who are older who do well with outcomes. So what we found is that frailty may be one of these key features that helps us predict who's going to do well, even out of the age groups. So the study also looked at frailty in the sense, so here they defined it as needing support with ADLs. So that would be someone who would be at least moderately frail. For those people, only 1.1% of people who needed help with ADLs to begin with had good neurologic outcomes meaning recovery to approximately the same level of function that they were at previously. So I find this can be helpful when you're talking about patients who are more moderately to severely frail and you're talking about CPR. Now, when I'm talking about critical care as well, frailties is also associated with outcomes for critical care. This is a study out of a geriatric ICU in China, and it looked at how people recovered their survival as well as their frailty index. What they found was that the higher your frailty index, meaning the more frail you are, the higher your mortality. Some really interesting points I found out of there is that no one who had a frailty index of greater than 0.46 who ended up in that geriatric ICU, none of those people survived past 3 months. Whereas everyone with a frailty index less than 0.22 survived at least a month. So it tells us frailty is a really strong factor in how someone's going to recover after a critical illness. Now that we've talked about the outcomes, I want to talk about what we can do to try to prevent frailty or reduce frailty to begin with. So when I see frailty, I want to think about all these things. I want to talk about their advanced care planning. I want to think about what's indicated in frailty. I want to look at their medications and consider adjustment of their treatment. But it also depends on their degree of frailty. So for someone who is quite robust, who is doing quite well, you're not noticing any frailty, we want to talk about prevention of frailty. And that's things like adequate nutrition, that's things like exercise, making sure that they're getting their appropriate preventative care, screening, dental health, making sure that their vision and their hearing is good, and trying to get them engaged in the community, trying to make sure they have social supports. So we talk about volunteering, for example, for someone who is really well, making them feel like there's a lot of meaning to their lives as well. As we're approaching someone who's a bit more frail, I'm thinking more about optimizing things. I'm trying to reduce social isolation. I want to talk about falls prevention. I want to talk more about advanced care planning, thinking about things like power of attorney, representation agreements. I want to talk about how we can optimize their medical conditions, trying to review their medicines, trying to see if there's any medications that maybe aren't indicated that are maybe causing side effects. As someone's starting to become frail, like mildly frail, I'm thinking about what sort of supports they might need, what sort of medications they might benefit from, and any sort of assistive devices. As they're becoming more moderately to severely frail, that's when I'm talking about treatment goals, reducing harms, thinking about risks and benefits. So we know that exercise is quite helpful, even in patients who are frail. Studies have found that even low levels of activity in people who are frail delayed the onset of dependence. So it kept them independent longer. So if you can get your patients to exercise, which granted is hard, trying to motivate someone to do this and encourage them, there is evidence that it improves their independence, and everyone wants to be independent as long as possible. Whatever form of exercise they enjoy is what I recommend. So anything that is going to be easy enough for them. Nutrition is also important, so trying to prevent weight loss. So we talk about adequate protein intake, so making sure, often it's things like animal products, eggs, things like that. Sometimes people need to take some protein supplements. There's Boost, there's Ensure. There's also some people who like to mix protein into things like smoothies. Typically the best absorbed is going to be whey protein. So I try to encourage that. And I try to encourage maintaining weight. Because there's some evidence that keeping a slightly higher BMI, not in the obese overweight category, but a higher BMI as you get older is more protective. And then all the other things I talk about, like socially engaging, making sure they're getting their routine health care, staying mentally engaged. I tell patients that there's an old saying, if you don't use it, you lose it. And that's sort of my spiel into making sure that you're staying mentally engaged. And we know hearing as well is very important. Care planning, we're talking about all these things, what their concerns are, their history, their care planning, and revisiting these things. and I'm talking about management and conditions, I want to make sure that everything that we're doing for patients who are more frail, this is for people who are more in that moderately severely frail, I want to make sure that everything we're doing for them is still in their best interests. You can help prognosticate people separately as well. So there's a site called ePrognosis. It contains a number of different scales for prognostication. It looks at community dwelling, inpatient, nursing homes. So you can pick your population, you can pick your scale based on the index. And it has questions about what their general function is, what their medical conditions are. There's different ones depending on what you're looking at, like a 2-year prognosis or a 4 to 10-year prognosis. And then once you fill that out, it'll give you this calculator's estimate of their prognosis. It is not a crystal ball, but it can help guide the decision making. The next thing I talk about is deprescribing. So I'm talking about their overall goals, their prognosis. I'm talking about how their medicines are actually taken. I find many patients who come into my clinic, they're not taking their medicines exactly as prescribed. They're taking it slightly differently. They're taking it twice a day instead of 3 times a day, something like that. So trying to make sure you know how are they actually taking it. And then I want to think about any harms with it, any side effects, any burden, like for example, warfarin, do they have to get their labs checked every 2 weeks? That's becoming more difficult for them. Do I need to set up mobile labs? I want to think about, is the medication still indicated? If their prognosis is very poor, then perhaps I don't need a primary prevention statin or a primary prevention aspirin. I want to think about what could happen if I stop this medication, and then think about making a change slowly. I only make changes one at a time, and I make sure that the patients, they can call me if something changes. I think we talk about more lenient targets with frailty. So for hypertension, for more frail patients, I talk about patients who want to keep their blood pressure in a range of 140 to 160. So there is talk about more strict targets like the SPRINT trial and such, but it excluded a number of patients who would be frail, like the diabetics with orthostatic hypotension and things like that. And then for diabetics, again, A1C of 7.5 to 8.5%, reducing the risk of hypoglycemia and falls. And for me, I think weight loss is a really big trigger for this. Often weight loss, their blood pressure gets better, their blood sugars get better. And if we keep them on the same doses, they can have side effects and they can have falls and lows. There's a tool, there's a stop tool, there's a start criteria. There's also the stop frail tool. So this is specifically to help in patients who are frail, like people who have moderate to severe frailty, whose prognosis is quite poor. And it just looks at a number of different medicines that you can look at and you can think, maybe my patient doesn't need this. The other thing I talk about with moderate to severe frailty is planning that they have proper recovery, that, for example, if they're going through surgery, that they expect that it could take them months to recover, and that they should have someone around to be able to support them. I want to think about things like how might they tolerate chemotherapy, invasive interventions, and do we need to keep screening for malignancies that might affect them 10, 15 years down the line if their prognosis is only 2 or 3 years. So for me, when I'm talking about advanced care planning, I talk about goals of care. So based on each patient, what their goals and values are, I talk about how I frame how frailty affects it, like CPR, ICU outcomes, and I talk with them about realistic outcomes. I also, for everyone, I talk about future planning, getting a power of attorney and a representation agreement. And I say this is for anyone because accidents can happen. You could get hit by a bus and you want to make sure that you've got care planning in place. There's a couple of good resources, Planning for Your Future through the People's Law School, which is free online. And there's the My Voice booklet through the Government of BC. And I use both of those regularly. So that is my whirlwind approach to frailty in the older adults. And basically the bottom line is frailty is associated with worse outcomes, but screening, prevention, and then if someone's becoming moderately severely frail, talking about adjusting therapies, adjusting targets, and things like that. Okay. And I will pass the stage back.
Thank you so much, Dr. Rodas. And just a friendly reminder to everyone that if you have any questions, to please pop in the Q&A box at the bottom of your screen, and we'll getting to those at the end of the presentation. So now I'll pass things over to Dr. Grace Park, and I'll let you talk about the CARES model.
Hi, everybody. Can you hear me? Is the audio working okay for me?
Yeah, sounds good.
Great. Okay. Let me, oops, sorry. Let me just try that again. Okay, I think it's now working. Thanks very much for joining us, everybody. And thanks, Katie, and for Shared Care for this opportunity. I'm really delighted to be here to talk to you about a project I've been working on for the last 6 years within Fraser Health, and really happy to share with you some of our learnings and hopefully to interest you in doing some of the work that we've been doing as well. So we have good news. We have Canadian life expectancy over the years has been rising, as you can see. Along the x-axis, the year that you were born, and gradually the life expectancy has been increasing. And this goes up to people born to 2005, and it's gone up a little bit higher as well. So this is outdated, but it is a little bit higher, but it's good news over time. But we also know that the other side of things is that even though we're living longer, many Canadians are living the last 8 to 10 years of their lives with frailty, and we can do better. We know in our practices in primary care that many of our patients are at risk. As Dr. Rodas talked about, they're vulnerable. They're pre-frail seniors living in the community. They still look like they're independent, but they can have something happen to them like a flu or a fall, and you know how quickly they can decline. So it's really great to know that there's now evidence that we can intervene and we can actually prevent the decline into frailty, and that becoming frail is not necessarily a thing that happens as you get older. And being in primary care, we're really well positioned to watch our patients as they get older, as they become more vulnerable, and try and intervene. So with frailty, we recognize that there is heterogeneity. As people age, they look different. They can look like this fellow who's maybe at a clinical frailty scale of 4, getting vulnerable. But as people age, there is a variability in their mortality rate. So as they get older, it really is variable. So that is a measure of their heterogeneity. And with frailty, we can actually address all of that. And you can actually look like a very robust person at the same age and have a lot less frailty. So the early identification of frailty in primary care is really exciting, especially as we use the accumulation of health deficits definition of frailty. We know that as we age, we have an increase in the number of deficits increasing each year of about 4.5% increase per year, and it doubles in 15 years. So between the age of 75 to 90 years, we actually double all the things that are wrong with us. And we know that in 2021, the leading edge of the baby boomers hit 75. And during those 15 years, more things will go wrong with them. So the opportunity for us to catch them before that, so between the age of 60 to 75, the 15 years prior, we can actually intervene and reduce the number of things that are wrong. And so there's less chance of those things doubling over time. And then with assessments and intervention, we can actually reverse some of those health deficits and to prevent that further progression of frailty. So the frailty index that Dr. Rodas talked about earlier is a very sensitive measure of frailty progression and whether the interventions that we put into place is effective. So when we look at frailty index, it goes from 0 to 1, 1 being the highest, 0 being the lowest. And generally in non-frail population, the frailty index is 0 to 0.08. And then as we get more into the pre-frail, it goes up to 0.24, and we consider frail at about 0.25. And when we get to a frailty index of 0.5, we have a nearly 100% chance of mortality at 20 months. And a frailty index of 0.7 is usually at end of life. And so it is a very sensitive measure. And in our pilot study with CARES in a cohort of about 50 seniors that went through our intervention program with community peer coaching and exercise, we showed an improvement of 0.03 in a 6-month period with the coaching and the exercise that was the intervention. So the CARES model then is a targeted initiative that we work with primary care providers. And so we've been working with divisions of family practice within Fraser Health. And we're looking to partner seniors, the patients that belong to the GPs, and partnering with community organizations as well. And we put a lot of emphasis on the development of an electronic comprehensive geriatric assessment that develops the electronic frailty index, and it is within the patient's chart in the EMR for the physician to be able to embed this process within one session as you're doing the comprehensive geriatric assessment. So it is a tool that can be used to document your assessment and measure the frailty index at that point in time, and also intervene with care planning and contribute to reducing the health deficits. So the comprehensive geriatric assessment that we have developed it in the IntraHealth Profile EMR. Oscar is coming. We're in the process of working on that right now. TELUS Med Access, TELUS Wolf have the EMR completed. And then we have a standalone version for other EMRs. And we're working on a web-based version as well that people can access off the web, and that's coming towards the end of this year. So it will be readily available for people who want to use this. And we have a research process going on where we've got some LPN support, and we're studying the comprehensive geriatric assessment and the frailty index at baseline 6 months, 12 months, and 18 months to assess the progression of frailty and the types of intervention that the patient is participating in. So this was a clinical frailty scale that Dr. Rodas talked about. So we're really looking at a scale of 3 to 6. Once they're getting to be more like 4, you can see that they're getting more vulnerable. And then at 5, they're starting to have difficulties with the higher order IADLs, with things outside of the home. And with 6, we're looking at people that are having problems with ADLs with things inside the home, such as bathing, keeping house, that kind of thing. So that's a quick screening that we do with our patients. And if they fall into the category of 4 to 6, then we can offer them a more comprehensive assessment. And that's the tool that Dr. Rodas showed us earlier. So this tool covers a lot of domains, and it looks really busy. And it takes a couple of tries to sort of become better at it. It basically run your mouse through it. And you can actually delegate portions of it to your staff. If you have nurse or LPN helping you and your staff, you can have the staff do the mini cog that was discussed earlier. That's a quick assessment for cognitive screen. The 5 times sit to stand as well, that can be a delegated task. And then you can run through the rest of it, and the physician administered tools. At the bottom, we have a list of problems and list of medications. And so that's where you can actually look at all the medications the patient is on, and you can do your de-prescribing and look at the problem list, update the list, and make sure that you're doing that comprehensive assessment that we can do once a year. And then you can move on to what office assistants can do, is faxing further referrals that are required, and then the social prescribing that I can talk about soon. And then even the IADL and ADL deficit fields, which take up the middle third of that form, that can be done by somebody else as well, just going through what sorts of things they're independent with, what sorts of things they need help with, etc. So doing the assessment is one part. That's a very important part, but really the big thing we want to do is to do a care plan. And looking at all of the things that you've uncovered as being problematic for the senior, you can address those things. You can review the goals of care with the patient and really see what's important to them. You can do your medication review, the advanced care planning that Belinda talked about, and then you can reassess the plan on a yearly basis, and that's your basis for the care that you provide. And so we liken this to the RORCS developmental screen that we do with our pediatric patients. This can be your seniors assessment that you do on a yearly basis, where everything is in one place and you cover all of the areas that Dr. Rodas talked about that contribute to frailty. And then along with that sort of care plan development, we now have added the social prescribing section, and that's the development of a wellness plan, where we look at the health protective factors, such as a healthy diet, socialization, exercise, caregiver support. And those are areas that take some time to delve into. And so we have added now the social prescribing section, which is where we've connected intentionally with community-based senior services and is supported by United Way. So there is a single point of entry and a contact person in one nonprofit organization in each of the communities within Fraser Health. And so we have link workers. They're now called, in our community, we call them, in Fraser Health, we're calling them seniors community connectors. But the idea comes from the UK, and they have the link workers, and that's similar to what we have as the social prescribing. So the health protective factors, the nutrition support that Dr. Rodas talked about, and socialization, and we know how important socialization is for seniors, and exercise, and really looking at barriers to improving those connections in the community, and then inquiring about caregiver support. And each of the community organizations that we have in Fraser, they have a caregiver support program, and that's really helpful so that the seniors can remain independent and stay in their own homes. So the partnership that we have with United Way has been really helpful. And the seniors, United Way has funded a seniors community connector in each of the communities where we have a division of family practice. And so between the division of family practice and the health authority and the nonprofit organizations, we come up with a program, and that's where the GPs can refer directly to a seniors community connector who reports back as to what they're finding with their interactions with the senior and their family. So the integration that we've managed to do with CARES program is the health services and social services integration. And I'm really happy to have established that through our partnership with United Way. And the integration that we've established then is with the healthcare providers, so our GPs, our gen nurses, our geriatric emergency nurses in all of our hospitals. Home health, community health nurses, and social workers are also referring their patients directly to the seniors community connector to try and improve those health protective programs like exercise and socialization and caregiver supports. And so together, this integration helps to prevent frailty because we can address all of those different factors, because it's not just the physical and the psychological, it can be cultural, can be financial, and all of those things that need further exploration, which can be done at the Seniors Community Connector. So this is the simple idea that we borrowed from, or stole actually, from the UK. They've been working on this for a couple of decades now. So the healthcare professional identifies patients having some non-clinical issues that need some further exploration. And then the link worker, our seniors community connector, connects with the patient once they receive the referral from the GP and makes available to that patient and family all the resources in the community, but not just showing them all the resources or telling them about it, but actually doing an in-depth interview as to what sorts of things would be acceptable to the patient, what would be culturally appropriate for that senior and the family, and what are the barriers in accessing some of those services. And the barriers, as I said, can be physical, can be financial, etc. And the nonprofit organizations have a huge support structure with their volunteers, transportation services, etc., that can actually help the senior to overcome their barriers. So this is our local senior center. There's an intergenerational kitchen, there's bus trips and tours, a pool game, and there's lots of activities that we don't really know about as GPs, but they're out there, and the Seniors Connector can refer them and connect them as able. So this is sort of a summary of our CARES collaboration, and through our work, we've actually come up with some educational material for GPs, so billing information, basically your complex care planning, your conferencing fees, etc. And we've also developed an educational video by Dr. Ken Rockwood, who is the author of the Comprehensive Geriatric Assessment and the Clinical Frailty Scale. So that video is really helpful, and it goes step by step on how to complete your assessment. And we do have a research grant that's allowing us to continue to study the electronic geriatric assessment. Our partnership with United Way has been integral to our success, I think, of late, and particularly in the last year, connecting with their NGOs in the community. And then we've also now connected with our practice support program coaches in each of our communities, where we have physicians who wish to look at the care they provide to their seniors with view to a quality improvement initiative. They'll get the support of their PSP office coach, along with the CME credits and sessional funds to really address case finding within their practice panels and putting into place things that they can do to trigger comprehensive assessments and care planning and social prescribing. So in summary then, so this is the model that we've been developing in Fraser Health, and we've documented a lot of things and we wish to share them with you. We have developed some toolkits that are available. And we do have the electronic geriatric assessment in the EMRs that I mentioned, also in the standalone versions for EMRs that are not in the ones that have completed. We do have the social prescribing in place now throughout Fraser Health. And so we actually have a community of practice of all of our seniors community connectors. And so patients, if they come to me and they live in another community, my seniors community connector will refer to the one in the patient's community. So that's been really great to be able to share that. And to be able to do a wellness intervention along with their care plan, I think is a comprehensive, holistic approach. And all of the issues are in that one document. And so it's nice to see it in one place. And we do have ongoing evaluation along with evaluation of our social prescribing program in partnership with United Way. So we're trying to be as robust as possible. And this is our some of our resources. I'm the physician lead at Fraser Health, and you can email me anytime if you have any questions. And Bobby Symes is the director at United Way. And so if you have questions regarding social prescribing, if you wish to see it in your community, you can email her. If you Google Fraser Health and Cares, you'll get some background information. We keep trying to add more documents to that. And acutefrailtynetwork.org.uk has really great information about the use of the clinical frailty scale and a lot of backgrounder on frailty. So that's just really helpful information. So I can stop there, and I thank you for your attention, and I'd be delighted to answer any questions.
Wonderful. Thank you so much to both of you. This has been great. We have some good questions in the Q&A box. So I'll start at the top. Excellent presentation. If you were to start with one or two community-wide interventions to reduce frailty, what would they be?
I can start there. The connection to the social connector, I think, was the key. You know, we have a lot of things going on in our community, but we can't keep track of them, and programs come and go. So having this one person in the community at a chosen NGO that is a community-based senior service organization has been really helpful, because that one person keeps track of what's current and what's coming. And then the United Way actually supports through grants all the time as to new programming. And then the local community division or GPs can stay in touch with that NGO. So that would be the one thing to try and establish. But if we were to try and get a couple of things in place, it would be exercise support, so peer support through volunteers or through Self-Management BC. They do phone peer counseling, and then social activities. And so a way of increasing socialization. And we have real concerns about socially isolated seniors, and we need to do a lot to try and get them the confidence to try and step into some of those community activities. There's so many of them, but they don't have the confidence or the knowledge of the activities, and so a way of getting them out to those social functions.
Yeah, I agree with everything that Dr. Park says. Like, I personally am a big proponent of exercise, and I think exercise can benefit basically everyone. So I think it's really helpful. And I also really like community centers, partly for that reason, because they have social integration as well as exercise. I think it's great to marry those two together.
Great. We have a few questions asking how the social prescribing has been affected by COVID. Can you speak a little bit to that?
Yes, we've had a lot of troubles, of course, because programs shut down initially. But throughout the year, there have been a lot of work to try and establish virtual connections. So there have been a lot of sort of social connections through Zoom, cooking, classes held through Zoom, conversation circles, and even exercise programs through Zoom for seniors. Then, of course, you need to have some tech savvy to be able to access that. But they're doing their very best, and they're actually doing a lot of phone calls to seniors as well that they know are isolated. So it's been difficult through COVID, but everybody's trying to adjust, and we're all very aware of the importance of connecting with seniors, and increasing social isolation was just the worst thing that could happen to them.
Right, we have a few questions about how do I access this toolkit? Is the referral form in Med Access? Are there similar programs available in Vancouver Coastal Health? Is it linked to Primary Care Network? Maybe you can speak a little bit more about access to this tool.
Sure. So yes, it is on Med Access. And if you have a support person through Med Access, they'll tell you how to get it. We have one community in Langley that's been using Med Access now. It's recently been launched and available. So it's available through Fraser Health right now. We can spread it, and I'm hoping that this was the beginning of trying to spread it and seed it into other communities. And I'm hoping that you see the value in this comprehensive geriatric assessment. And the tool is available, as I said, for those EMRs and even for standalones. So physicians who use an EMR that's not on that list, you can email me and we'll make that available to you. We have a small team of people, including some very tech savvy people, and we'll make that available to you. Was there another part?
Oh, is it linked to the primary care networks or home health?
So in home health in Fraser, we're connected to the social prescribing. Vancouver Coastal will have to catch up. We'll help you as much as we can. PCNs, this is rolling out through PCNs in Fraser Health. And so through the rest of the province, I think if we can seed it into the PCN work, that will be really great.
Great. We have a couple of questions around the My Voice tool or resource. Someone's asking if using that My Voice tool for representation agreement, must the patient have it notarized as shown on the last page, which is page 47 of My Voice?
For the My Voice document, it does contain the representation agreement. You can also print it out separately from the BC government. It doesn't have to be notarized. It can be done with 2 witnesses, and it tells you who would qualify as a witness, like relatives, that sort of thing. I usually recommend it gets done with a notary just to ensure that everything's done appropriately, because it is something that's important. But it could be done with witnesses through either the My Voice booklet or the printouts.
And someone just asking if the My Voice document has been revised.
That part I'm not sure of offhand. I don't think I've seen a more recent version of it. I actually personally really like the planning for your future from the People's Law School. I think it's got a lot of useful information, and it doesn't have the actual forms themselves, but it describes the importance of them as well as just advanced care planning in general.
Thanks. I think we have time for just a couple more questions. So someone's wondering who pays the connectors?
That's United Way. So United Way had a granting stream called High Needs Grant. And so they did fund all of the divisions of family practice for a seniors connector, along with 10 other communities in BC. It's a demonstration project, much like Better at Home was a demonstration project that became an ongoing funded program. So we're hoping that this will produce lots of connections between primary care providers and nonprofit organizations. And we see benefit in the evaluation, and then it will hopefully become a permanently funded process.
Great. And one question, do you have any suggested resources to give to families or patients to help explain what frailty means to them?
I describe frailty as just that syndrome of vulnerability, that accumulation of illnesses over time that just add up to have an effect on your body, even though one individual one or two individual ones don't have an impact, just the interplay of all of them together. I actually really like the Canadian Frailty Network website as well. I think they've got a lot of good information that's very patient language based. It's hard if they aren't very tech savvy, but often someone in their family could at least help guide them to that website and to maybe even print out parts of the website for them.
Yeah, I agree with that. The Canadian Frailty Network is a really great resource, and we keep adding to our Fraser Health resource site. And so I think I'll develop something for patients, and I might take some stuff from Dr. Rodis's presentation today and then create something and put it on there for family. But I think the key is to just talk about it a lot as a thing that is preventable and that you don't have to become frail as you get older. And as Belinda said, it's colloquial. People talk about social frailty and people talk about other kinds of frailty. And so, we have to talk about it clearly as accumulation of deficits and that there is something that you can be done about that. And intervention is really the key.
Awesome. Well, that's all the time we have right now. We're just at 7. So I will say thank you so much to our panelists, Dr. Belinda Rodis and Dr. Grace Park for this. And thank you to everyone for joining us this evening. We will be sending out the recording of this webinar with the other answers to the questions we didn't get to this evening. And if you have any further questions, you can email me or Dr. Park, and our emails are on the screen here. Thank you so much.
Thank you.